Welcome everyone to this briefing. Good afternoon. This briefing is on determining best strategies for allocating the pharmaceutical settlement dollars to abate the opioid crisis. And this is part two in a two-part series. My name is Diana Fishbein, AKA Denny, for those who know me. I'm at the University of North Carolina in Chapel Hill in the Frank Porter Graham Child Development Institute. I also hold a part-time position as research faculty at the Pennsylvania State University, and I am the founder and co-director of the National Prevention Science Coalition, which is the sponsor for this briefing. The Prevention Science Coalition is the first organization in the United States to transfer knowledge and practices amassed from prevention science into public health policies. We have over 1,000 members with expertise from across a whole spectrum of disciplines that are relevant to prevention. And we also routinely reach thousands of others, as well as policymakers at all levels. We work largely federally to inform legislators and agency officials about prevention science and its relevance to public policy. And we also work with states and local communities to encourage adoption of evidence-based preventative strategies. So why is it important to invest in evidence-based primary prevention strategies to combat the substance use crises, with a very important opportunity now with the pharmaceutical settlement monies? So this briefing will focus on what the science of prevention has shown to be effective in combating our current opioid epidemic and quite frankly, other substance use crises by disrupting pathways to substance use in young people before they start to use. And this approach is part of a continuum of care, including measures to address problems that have already become entrenched, including treatment and recovery supports. But the science suggests that primary prevention should be prioritized if we really want to make a dent in the problem. The evidence, some of which will be presented today, is compelling that a more balanced approach between treatment and prevention will be best and most effective use of the settlement monies. And the greatest gains can be made by building community-based infrastructure to support the delivery of well-tested primary prevention strategies. Importantly, we will also hear from 2 states that are implementing evidence-based strategies to tackle this problem from multiple levels. And we will hear about a technology being made available that can aid states and communities in identifying solutions that best meet their needs. These are the speakers from part 1 of this 2-part series, and we featured experts in the science of addiction, including adolescent pathways and preventative approaches, as well as a landscape analysis of how the settlement monies are currently being expended across the country, in addition to a technological innovation that guides decision makers through an evidence-based platform to determine how to achieve the greatest return on investment. And you can see the site here for the kkfhealthnews.org that has very important updates about how settlement monies are being used. And we can add that to the chat later. Our expert speakers today in the second briefing are shown here, and each one will be introduced right before they speak. They will discuss we're going to actually flip the order a little bit. Mr. Zeke Cohen, the new Baltimore City Council president, congratulations, will go first because he had a meeting come up. But generally, we're going to discuss proven prevention approaches and also talk about the context of racial and social inequities and disparities that precipitate these crises. And then the speaker, Dr. Sarah Whaley, will describe the Johns Hopkins University principles adopted by various localities throughout the country that provides guidance for selection and implementation of best practices. The work that Zeke Cohen will talk about is in Baltimore City to heal trauma by applying comprehensive cross-sector approaches using these dollars. And we'll also have a state-level exemplar in Rhode Island by Kathy Schultz, talking about ways in which significant investments can and have been made in evidence-based preventive interventions. And then finally, we feature Rayford Etherton again, because he has a simulation technology that we feel is so important for folks to know in localities that can help them determine strategies that are most effective and cost efficient for any given location, and how it was specifically applied in Mobile, Alabama. Here are the interns that are working with us at the National Prevention Science Coalition. Anshuta Biram, Vanessa Morales, Doyan M, and Maddie Jupina, and they will be introducing each of the speakers. Anshuta, you are on.
Thank you, Denny. A former teacher and nonprofit teaching community founder, Mr. Zeke Cohen has served on the 1st District Baltimore City Council since 2016 and is currently the Baltimore City Council president. He cares deeply about Baltimore and introduced the Elijah Cummings Healing Act in 2019 with the aim of helping Baltimore heal from trauma, racism, and violence. Thank you for joining us today, Mr. Cohen.
No, thank you, Anshuta. I really appreciated that kind introduction, and thank you all so much for having me here today. And I'll just preface my talk. So the city of Baltimore made a strategic decision that we disengaged from our state's universal settlement and decided to essentially go it alone around our opioid funds and our pharmaceutical lawsuits, largely because Baltimore has been ground zero of where we see the opioid crisis show up. And we just felt like we would do better by having our own lawsuits. And that has really, really, really paid off for us. Our city solicitor has done an outstanding job. And I do want to really thank Dr. Sarah Whaley, who's been working really closely with us on standing up a really strong opioid restitution fund and helping us determine through an evidence-based approach how to think about spending our funds. So the work that I'm going to talk to you about today preceded these lawsuits, and it was actually following a first slide, please. So it was actually following a school shooting that took place in West Baltimore. Frederick Douglass High School is a historically very proud but disinvested school in West Baltimore with a amazing history in our city. And in 2019, they suffered from a horrific school shooting where a guy walked into the school with a gun, shot one of the school staff. It was just incredibly chaotic. Bullets, students described hearing bullets flying. Just a horrific, awful scene. Next slide, please. The city council decided to, hey, I think we actually have the wrong PowerPoint, Margaret. The one that you sent me is the correct one. Or I think we might have missed a slide. Sorry. Could you go back one slide? There you go. All right. So sorry about that. So I was chairing the education committee of the city council at the time, and we decided to hold a hearing in our committee. And the idea was youth voices, youth violence. We really wanted to hear directly from young people themselves who had been impacted about what we could do to mitigate their exposure to gun violence, and particularly in light of this horrific school shooting. And I will say that at the time, a lot of the adult conversation was about, should we have more metal detectors, or should we have our school police be armed? But when the students went up to speak, and the young people you see in front of you in this slide is Jayana, Damani, and Brianna, who were juniors at the time of the school shooting, they didn't want anything to do with that conversation. And what they said to us was, listen, if all you're talking about is how to better police us, then you're missing the real conversation, which needs to be about how we prevent violence from occurring in our lives in the first place. And they listed every ACE, adverse childhood experience, in the book. They talked about exposure to gun violence. They talked about their own issues with food insecurity and housing instability, and in a way that only young people can, with just incredible authenticity and poise, really named every single traumatic experience that children in our city, particularly Black children in our city, grow up going through. And they pointed at us and said, listen, City Council, that's what you all need to address, not just more metal detectors, not just school police having guns. Like, that's where we want you to focus your energy and resources. Next slide, please. I am a former teacher, and when young people speak with that level of precision and clarity, it behooves us as policymakers to listen. So I went up to Jayana and Damani and Brianna after the hearing and said, "You're absolutely right. This issue of trauma is so impactful in our city. But instead of me just going back and writing a policy, which is normally what we do, what if we work together and did a listening tour across our city, and you all help to shape this legislation?" Because I believe that your lived experiences, your voice, and what you were able to communicate in this hearing would contribute to far better legislation, a better law than what I would be able to come up with myself. And they were really kind. They said yes. And so we started this listening tour in laundromats, in rec centers, in classrooms, in City Hall, all across the city of Baltimore. Next slide, please. The other thing that we did was just a national scan, looking at what other cities were doing. One thing we realized is that a lot of cities are doing a lot when it comes to healing and addressing trauma, but no one had really legislated a trauma responsive approach. And we saw that as a unique challenge for the city of Baltimore to take on. And so about a year later, we brought together young people, older adults, communities of all shapes and sizes, and we held our first ever Healing City Summit. The young people came up with the name, and it was a youth-led series of panels and TED Talks about how to help people in Baltimore heal from trauma. Next slide, please. This young woman delivered an incredible poem and then quite literally dropped the mic. Next slide, please. The next day, we went over to Coppin State, which is our other large HBCU in Baltimore, and we held the community fair day of our Healing City Summit. And we had barbers and beauticians giving out cuts. We had nonprofits. We had every sort of service you could imagine. One thing I'll say quickly on the barbers and beauticians, as we were doing this listening tour, a good friend and mentor of mine, a guy named Troy Staten, pulled me up, and he's a barber. He was shot in his barber shop, and he runs this nonprofit called More Than a Shop, where they teach, they do blood screenings, they do healthcare in barbershops. And Troy said to me, he was like, listen, don't overlook the barbers and the beauticians when you're doing your Healing City Act thing. Like, we are leaders in our community, and we have a close connection to this issue of trauma and violence. And I said to him, like, hey, what do you mean by that, Troy? And he was like, well, look, we as barbers literally put our hands on people, and there is something deeply healing about touch. And when folks come into the barbershop, they are honest, they are vulnerable, we can have real conversations, unlike sometimes in a hospital setting where folks feel stigmatized. And the other thing he said that I'll never forget, he said, and look, when you put your hands on someone as a barber, you know that we are not only touching the victims of violence, we're also touching the shooters. And you will never know whether that one touch, that cut that you gave somebody, may have prevented them from going out and using their gun that night. And so you need to make sure that you keep close with barbers and beauticians in this work. And that hit me really hard because, Troy's one of those guys, when he speaks, you listen. Next slide, please. We marched with the Frederick Douglass Marching Band from Coppin State to Frederick Douglass High School. Next slide, please. Where Brianna, Jayana, and Damani spoke again, but not just about what it was like to have been in this school shooting, but what it was like to have helped to write a bill and advocated and legislated and lobbied for it, and really how they were able to take their power back over this horrific experience. Next slide, please. And then our mayor at the time, who was Jack Young, signed the Elijah Cummings Healing City Act, named after the late great congressman who held the first hearing on childhood trauma right there in their auditorium. And it was just a very proud moment for our city and for particularly these young people who drove this bill. Next slide, please. What does our legislation do? It creates a task force of 38 people to assist in the development of a citywide strategy toward an organizational culture shift into making Baltimore a trauma-responsive city and government. So we have a big task force, and they have a intra and inter sectional approach. They represent folks from hospitals, academia, government, et cetera, et cetera, et cetera. And we work together on strategies to reduce trauma in our city. Number two is that it called for training of all city agencies on trauma-informed care. And our trainings are deep. They are a year long each for each agency. We contract with a group named Sage Wellness. But it is not like a one and done trauma 101 kind of thing. It is like we are going to go really, really deep. We're going to start by talking about race-based trauma and, in a city that was one of the birthplaces of redlining, what that has done and what that means. And then we go from there. Finally, at the end of our trainings, we review policies and procedures within our agencies to ensure that they are aligned with a trauma-informed and equitable approach. Next slide, please. Here is just a shot of our training facilitators. The thing I'm really proud about is that they're all Baltimoreans. For anyone thinking about trying to do this at home, highly, highly recommend that you do not just go out and seek like the hotshot trauma 101 consultant from some other place, but actually like lift up your own talent, because I can guarantee you got folks that can do this work. Next slide, please. This is a shot of, big shout out to Holistic Life Foundation. Amazing, amazing partners in the work. They do mindfulness. They're incredible. This shot, obviously, it was during the height of the pandemic of our task force getting sworn in. That's our new mayor, Brandon Scott. Those are some of the task force members. We're all outside and masked up, but we are in the process of being sworn in. Next slide. These are some of the subcommittees on our trauma-informed care task force. You can read them, but there's a focus on medical, there's focused on youth, decolonizing, and so on. Next slide, please. So the first agency we trained was our library system. Baltimore has a really proud, what's called the Enoch Pratt Free Libraries. That's our library system, and our libraries are amazing, and they are spaces of civic innovation, and they are just, frankly, places where it's like one of the last places on earth where the public can go, whether they're people experiencing homelessness or folks who are struggling, to the topic of this briefing, with addiction, or just kids. So this is an article from the Trace. Baltimore bets on a new type of first responder, the librarian. Next slide, please. I mentioned that at the end, we do this policy review within the agency. So when we got done training our Enoch Pratt staff, they the head librarian Heidi Daniel, who has since moved on to I think Seattle, came to me and said like, "Hey, listen, as I'm looking at all these policies, the one thing that I'm like deeply, deeply uncomfortable with, very much to the purpose of this conversation we're having today, is that we have a zero tolerance policy in our library system for anyone who comes in either looking or smelling like they've used drugs or alcohol in the last 24 hours. It's zero tolerance. The policy is to write them up and kick them out and document it." And she said to me, like, listen, like, in the year 2021, I know that addiction is a disease. I know that it is a public and mental health disorder. And I know that Baltimore had a very dark history of criminalizing this disease. And I feel deeply uncomfortable with this policy. And if I get rid of my zero tolerance policy, I know that I'm going to get a lot of pushback from constituents or patrons saying, "Oh, wow, Heidi is encouraging people to party in the library and it's going to be off the hook and out of control." And so she said to me, like, what's something that we could bring in lieu of our zero tolerance policy that would actually help folks to be able to address the illness of addiction? And what we came up with together was peer navigators. And so who you see there is Donna, a very dear friend and the first peer to join our libraries. Peer navigators, for folks that are not familiar, and I assume most people on this call are, but it is an evidence-based approach. People who in the past have struggled with addiction, who are in recovery, who get certified, and then are able to help other people access services. What you see on the table is a kit that we provide. It's got Narcan, it's got resources, and it's whatever you need. You come in there and Donna will welcome you with open arms and make sure you get what you need. That could be a bus pass if you're looking to get into treatment, or even an Uber. Or in one case, we had a mom come in and all she needed was some diapers, and so Donna helped her get that. But it's really a harm reduction, evidence-based approach, and it's been beautiful. We started with one branch, and then we got a grant from Care First, and so now we're in 8 branches. And due to our opioid settlement, we're going to be in every branch within the next 3 months. Next slide. We used some of our ARPA money. The mayor was generous and put 1.4 million into implementing this work, sort of to the conversation we're having today. I think this is also a really good use of opioid restitution funds. Our mayor subsequently put another 5 million from our opioid funds into this work. But all that to be said, you got to be a little creative about how you pay for it, because you got to pay for it. And it's not free, and we don't exploit people's labor, and it's not super cheap either. And so if this is something you're interested in, just know there is a price tag and it costs money. Next slide. Initially, just Open Society was like our angel investor. The mayor signed the previous mayor signed our bill, but we were like head down into the pandemic, and so he was like not totally into funding it, and so I had to raise some money privately. But ultimately, Mayor Scott has come through in a huge way and deeply believes in this work, and so it's a public-private partnership. All right, like it's public and private dollars doing what they're supposed to do. Next slide, please. Here's some quick lessons learned. Legislation matters. I would encourage any of the policymakers that are on this call. I'm going to give you my email. Like, I think having a law change makes a big difference, because it's the law. And so it is going to outlive me. And even if subsequent mayors and city councils don't want to continue to do it, then they'll be violating the law. And so I think it is important, both as an anchoring sort of rallying cry, but also because then you can't just like shift away from it. Number 2, the work takes money. I mentioned that before. Don't shortchange it. Like, pay people what they're worth. We pay all of our trainers. We pay the kids. Don't exploit people's labor. There's a saying that a professor here at Johns Hopkins uses. She says, "We are the medicine. Assume your own community has the expertise and knowledge to heal." So again, the part of the power is that we're doing this collectively. It's not about, me. It's not about any one person or organization. It's like, this is Baltimore's law. This is Baltimore's healing city. And so, tap that in your own place. It can't just be government. Community needs to be invested and compelling the work forward. Really, there is no way to just like have the mayor and the council or whoever, whatever state legislature and governor, like it's got to be driven by community. Policymakers are extremely important. Agencies are important, but like if community doesn't see themselves in it, it's not going to go anywhere. And then finally, systems change is a long time. We've been working at our law for 3-ish years now. We've made some real headway. We trained the libraries, the rec and park. We've made some policy moves, but in it to win it. And this is a long game. And just know that, like, the wins are great, but often it takes a really long time to see real progress. Next slide, please. So I'll just close by saying, really proud of what Baltimore has been able to accomplish, and really, really, really long way to go. We have a great mayor who is just an absolute champion for this work. We have great partnerships with folks like Dr. Whaley and Johns Hopkins and Coppin and Morgan and all of our schools. But it's definitely the long game. And to me, when I think about the opioid restitution funds that we've all got, undoing some of the past trauma and harms, and particularly in a place like Baltimore, race-based violence is extremely important, and it has to be structural. It can't be like just a one-off kind of program kind of thing. It has to in my mind, be about our systems and structures that produced bad outcomes with many, many people suffering from addiction. And so, again, really appreciate you all giving me the platform. Thank you so much for being here together. And if I got any time left, would love comments, questions, and thoughts.
Zeke, we're going to be taking comments and questions at the very end, and I know you won't be able to make it, but perhaps we can interact with you in another forum afterwards. That was phenomenal. Thank you so much.
I would love that. Thank you so much. I really appreciate you, Danny, having me.
Absolutely. Take good care now.
And now we're fortunate to have with us Dr. Philip Graham, Principal Scientist at RTI International and Center Director of the Center for Behavioral Health Epidemiology, Implementation, and Evaluation Research. With over 25 years of experience, Dr. Graham has led community-based research and evaluations focused on the impacts of substance use, violence, and inequities on youth and their communities. He has directed national evaluations of SAMHSA-funded prevention strategies and is currently the principal investigator for the NIDA-funded HEAL Prevention Coordinating Center. Thank you for joining us, Dr. Graham. I'll turn it over to you.
Good morning. Can you hear me?
Yes, we can.
Good afternoon. Can you hear me okay? Good. Well, I want to just kind of put this in context. We had to move things around this afternoon to accommodate the city councilman. So Denny had asked me to really kind of tee up why we are here today. So I want you to remember what you just heard, but after I present, you will see how it would have fit perfectly in what I'm going to share with you. I will also go through this pretty quickly because I really want to make sure that you all have time to really hear the amazing presenters that will come after me. So again, what I'm going to share is really thinking about proven prevention approaches to how we disrupt the pathways around opioid addiction, and really focusing on racial and social inequities as you think about how you might use, in a very innovative way, these opioid abatement settlement funds. So I just want to put in context kind of where we are with respect to the epidemic. And as you all know, we moved from the impact of prescription drugs to really prescription opioids, to the impact of illicit synthetic opioids. And this slide just kind of shows you the context in which we are currently working. That bottom part of the slide shows you the percentage of deaths that have come from opioids and stimulants, percentage of just opioids alone, and also just stimulants by themselves. I show you this slide for a couple of reasons. Although we're talking specifically about opioids, I want us to remember that very few of these deaths occur by themselves. And so when we're thinking about strategies, is really looking at illicit drugs more holistically as we develop strategies to think about what works best among whom under what conditions. Here's where I want to spend my time this morning and really kind of understanding the changing epidemiology of the overdose. As we all know, originally the epidemic started with white males from the ages of 30 to 35. But here are two things I want to point out. Look at the increasing numbers among, and I hope you can see this, among Native American, Alaska Native individuals and Black African American. Over time, the epidemic has shifted in terms of who it's most affecting. And as we are thinking about strategies and thinking about how to use these funds, make sure you understand in your local communities what's currently driving the epidemic and who's been most impacted. Now, you will also see another trend, and as a early primary care, primary prevention specialist, I don't really look at older populations, but this epidemic has also talked about the importance of looking at older populations. So if you look here on the right-hand side of the slide, you see the ages between 55 and 64. That trend is continuing to go up, as well as 65 to 70. Again, as we think about how we might use these funds, I want us to make sure we are looking at the epidemiology of the epidemic in present time and making sure that the strategies that we're developing, offering, really fit with those populations. Again, this slide I want to show again in terms of looking at the ages of 12 to 24, which is where we normally think that we should be focused with respect to prevention. And again, you will see incredible increases among American Indians as well as Black African American. Again, these slides give you a context of what's changing among young people. But again, how do we think about strategies that really focus on these populations? I know we're talking about opioids, but I would be remiss to remind us, though, that alcohol, nicotine, and cannabis still remain problems for our young people. And you'll see in these slides that still the vast majority of substance use among young people in the ages of 12 and 17 and 18, 25 is not opioids at the time, but there are other drugs. And so we have to be mindful of that and not shift all our funds from one resource to the other, but figure out how to do it in an integrated way, understanding that young people are still impacted by these other substances. This is the other slide, and I keep saying this, right, that I really want you to pay attention to. The purpose of this slide is to also let us know that issues of substance use are complex. They're interrelated, and very little of it ever happens in a vacuum. And this slide is intended to illustrate that. And so where I want to focus today is where it says other challenges among high school students. And you will see, and I think it was represented by the councilman, young people encounter a host of issues and challenges in their daily interaction. And so until we fully understand, recognize, and compensate for that complexity, we often miss the boat. And so, for example, 45% of young people mentioned that they did not feel close to someone at school. Another 40% persistent feelings of sadness and hopelessness. All these things interact with why young people use substances. So understand, while you are focusing on a substance, what are the underlying things leading to why young people are using those substances? Also, there continue to be disparities as we think about overdose. And here again, two things I want to point you to. Most folks often think that opioid use more prevalent among males. These data suggest that actually you're seeing increases among female populations. Also thinking about LGBTQ plus communities, where you'll see higher levels of reported overdoses among those populations across a host of substances, including lifetime Rx use. And then to the right, you will actually look at the data as it's broken down by race and ethnicity. Again, we have to both disaggregate and unpack our understanding of the epidemic so that we can make sure we are selecting the best strategies. Now, this slide would have set up nicely the presentation by the councilman and understanding the importance of the impact of social determinants of health on outcomes, but also adverse childhood experiences. This is one of the main reasons as part of this work we continue to talk about how do we move upstream, understanding that these factors are critical to the outcomes of our young people. And until we really fully comprehend and understand what that looks like, we can slow down the epidemic, but really beginning to bend that curve will not occur until we're able to think about these factors in that context. So I'm going to briefly talk broadly about some strategies because you're going to hear, you've already heard some things that are going on in Baltimore, and then you'll hear two more presentations that really help you understand what are the most effective strategies for the communities you're working with. And in doing that, I want you also to think about this concept called contributory conditions. And you can see the definition here, but really it basically talks about the factors or circumstances that may not directly cause the primary issue, here substance use, but they influence its onset, its severity, and its persistence. And so as we are selecting and thinking about strategies, here are things that we need to really consider. You know, what are the mental health issues going on? Depression, anxiety, major factors that increase the vulnerability to SUD, OUD specifically. What are the socioeconomic challenges? Poverty, unemployment, housing instability. How do those impact those communities? We just talked about ACEs and really understanding not only the traditional ACEs, but these quote unquote non-traditional ACEs like exposure to violence, and then understanding the lack of social support or community resources. As we are figuring out those strategies, please think about these additional factors and creating holistic approaches to addressing the opioid epidemic. So just quickly, what are some proving strategies? We can think about this as operating at multiple levels. Things like life skills training with the right cultural context can be used in school settings. But also community-based processes are important too. And so many of you have heard of communities that care. One of the important things about community care is, in addition to selecting evidence-based strategies, it's about communities coming together. And so that process of coming together to plan and understanding your social and community context, data suggests that you have much better outcomes using these processes. And then thinking about families. And so I just used one here, strengthening families, as one example, but thinking about strategies that really support family cohesion and building resilience among young people as key factors of addressing the long-term impact of opioid use. However, I want to almost overemphasize the importance of moving upstream. So when we think about upstream prevention, it needs to be beyond individual or family interventions. Thinking about those broader contexts and social determinants of health will really help us think about how we sustain the impact of these strategies by incorporating aspects of what does housing instability look like in my communities? What are the economic opportunities, not only for young people, but their families more broadly speaking, and issues around access to health care. And then the bigger issue, and I think this was pointed out in the last presentation, what do policy and system changes look like? How can we improve access to quality healthcare? How can we begin to use Medicaid in addition to opioid abatement funds to understand how we fund these strategies? And there are issues like economic stability, safe housing directly will flow out of that as you think about those strategies. So my quick call to action is the following. Successful prevention of opioid addiction requires systemic changes that address inequities as central contributors to addiction. So understanding who's been affected and what are the strategies that need to really dismantle those systemic things that have been around that precede or come before we ever were dealing with the opioid epidemic. And the last is for all stakeholders, including healthcare providers, policymakers, and communities, must collaborate to create prevention strategies that are not only evidence-based, but also equity-centered. As I said before, I was going to go through this quickly because I'm much more interested in you hearing the general presentation that will follow. And so with that, I want to say thank you. Here's my contact information, and I'll be around to answer any questions that are needed. But again, this presentation was intended to set up everything that flowed. So now you can actually remember Councilman Cohen's presentation as we move forward. So thank you.
Thank you so much, Philip. That was outstanding. Do-Yeon?
Hello.
Hi.
Yep. Next up, we have Dr. Whaley. Dr. Whaley is a senior research associate at the Johns Hopkins Bloomberg School of Public Health and the program director of Bloomberg Overdose Prevention Initiative. She is dedicated to addressing the nation's overdose crisis by actively engaging in state-level policymaking to guide the effective use of opioid settlement funds and to implement evidence-based solutions. Also, her work bridges research and policy, fostering strong academia governmental partnerships to inform and shape impactful overdose prevention policies nationwide. Please join me in welcoming Dr. Whaley.
Thank you so much. Am I sharing my own slides?
Yes, if you would, please.
Yes. Okay. Let me pull, that's tilted down. Sorry, bad angle. 2 screens. Okay. Let's bring this over here. Sorry.
It's fine. We can all take a mindful moment.
All right. All right, can you all see that?
Perfect, yes.
Perfect. Okay, wonderful. I want to start off by saying I'm so excited to be here, and just one minor point of clarification. I am not a doctor. I don't have that qualification yet. But I'm Sarah Whaley. I'm faculty at the Johns Hopkins Bloomberg School of Public Health, and I work on a project called the Bloomberg Overdose Prevention Initiative. To set us up a little bit, the opioid settlements are often compared to the tobacco master settlements, where states sued the largest tobacco companies in the country and received around $246 billion that was paid out to these states over 25 years, with the intention that these dollars would be spent on tobacco prevention and cessation programming. What we saw most often was that these dollars went into the state's general fund and filled budget holes and were used for a variety of reasons kind of outside of the scope of tobacco prevention and cessation. And this really became a case study of what not to do. So in my work with the Overdose Prevention Initiative, we started to hear pretty early on that some of the states that we work with and other states across the country were asking kind of the question of, well, how should we spend our opioid settlement funds? So to kind of guide that question, we looked at how the opioid settlement funds were coming to different jurisdictions. So for the opioid settlements, there's going to be approximately $56 billion. The total is not quite known yet. But unlike the tobacco settlements, these funds are going not just to states, but also directly to cities and counties. And so with this variation, there's going to be different decision makers. And we also kind of thought about that the infrastructure in states and local governments looks different. This is not a new crisis. There is a lot of work that's already been done. And so making kind of broad blanket recommendations of how the funds should be invested might not fit depending on how jurisdictions had invested other funding sources. So with those two pieces in mind, Johns Hopkins started to coordinate the development of the principles for the use of funds from the opioid litigation, or as we call them now, just the principles. We released these principles in the end of 2020, beginning of 2021. But we really say we coordinated them because these principles were really written by experts across the field. We reached out to experts in the prevention space, in harm reduction, in addiction medicine, and really brought all of these folks together under this collective goal that we wanted the settlement funds to not be spent in the same way that the tobacco funds were spent. We really wanted to make sure that these funds were spent on this crisis because we know how important it is. And so with kind of all of that expertise together, the principles were released. They're 5 high-level guiding principles. They are really kind of process foundational principles. And since their release, they have been endorsed by over 60 different national groups, again, across the spectrum of folks working in overdose response. So from addiction medicine specialists, prevention folks, academics, kind of across the spectrum. And again, under this collective mission that we wanted opioid settlement funds to be spent addressing the opioid crisis. Since 2020, we have done over 28 tailored briefings in states. We have done additional briefings to state county associations, to counties, and to cities. We have seen the principles be incorporated or referenced in 22 different states, either directly in legislation, in their plans, cited by their boards, and then even more counties and cities are also using the principles. So I'm going to go through each one of these principles and kind of explain a little bit about what it is, and then give an example of what it looks like in practice. So principle 1 is to spend the money to save lives. Again, going back to what the mission of these principles are, is to make sure that they go to address the opioid crisis. And there's a few suggestions of how to do this: investing in programs, not paybacks, and using these funds to supplement the great work that is already being done, rather than supplanting or replacing existing funding with opioid settlement funds. We heard from Council President Cohen about, how he has piecemealed together private and public funding to support his initiative. And I think this is what we see with opioid settlement funds as well, is that they can be used to enhance existing funding rather than replacing funding sources. Because there is so much variation across the country in how states are approaching their settlement funds, we really encourage jurisdictions to codify their process in some way. We also heard Council President Cohen talk about when something is a law, it's a lot harder to change. And this is exactly why we make this recommendation. So this map shows how different states have approached their opioid settlement funds. You can see some have passed legislation, some have an MOU or MOA between the city or between the state and local governments, and then some have a combination of legislation and MOUs. And then at the local level, there's also city ordinances or executive orders. Principle 2 is to use the evidence to guide the spending. Again, this is not a new crisis. There has been a lot of investment in research to show what programs work, to show what programs are rooted in evidence, and also to show what interventions don't work or so don't have the intended outcomes. And so we really encourage jurisdictions to invest in programs that have been shown to work or that are promising, and then have additional investment in an evaluation to show that program is having the intended outcome. One way to do this is looking at data. We suggest that jurisdictions do a needs assessment. So this looks at both quantitative and qualitative data, so the numbers, and then also interviews from key stakeholders to kind of fill in the parts that quantitative data doesn't always show us. But around what are the current available programs or interventions in a community, how are those funded, what are the gaps in services and the key challenges that individuals who use drugs are facing. And then needs assessments can also tell us how effective those programs are. And so Dr. Graham just spoke a lot about some of the populations that are most needed, what are the drugs that people are using. This data can really help to guide how settlement dollars can be most effective. And we've seen a lot of jurisdictions use needs assessments, the state of Nevada, and then also like local jurisdictions as well can do needs assessments. Principle 3 is to invest in youth prevention. Again, Dr. Graham talked a lot about evidence-based youth prevention. Again, we know what programs work and what programs don't work. And so when we're thinking about aligning or investing in youth prevention, really making sure that our investment in these types of programs are in line with our intended outcome. If our intended outcome is to prevent substance misuse before it starts, how can we make sure that the program we're investing in does that? There are a lot of really great examples across the country of jurisdictions investing in the social determinants of health or programs that address either the risk factors for future substance use or programs that build up protective factors. One example here in Cambria County, Pennsylvania, they did a jurisdiction-wide needs assessment and found that there were really, really long wait lists for youth to see a mental health provider in their school system. And so because there was that need that they saw within the data, they were able to partner with the local university to increase the amount of mental health care providers for students in their county. Another example here is from Boston. They are using some of their settlement funds for what they call economic support for impacted families. One of the risk factors for youth future substance use is having a family member who has a substance use disorder. And so this program can help with some of those risk factors. Principle 4 is to focus on racial equity. We know that there are communities that have been disproportionately impacted by the war on drugs, by the criminalization of drug use, and that there are disproportional overdose rates currently. We also just saw that from Dr. Graham's presentation. One way to kind of focus on equity and to amplify those voices and make sure that we are investing in programs that are going to best serve those communities are by including those communities in decision making. This diagram, this slide comes from Alyssa Kitlis, who works in Wake County, North Carolina, and was a Bloomberg Fellow at the School of Public Health. She looked at this continuum, the spectrum of community engagement, and kind of laid out some activities for opioid settlement funds that are related to community engagement. And I want to focus on this one, an opioid settlement advisory group. So a lot of states and local governments have put together an advisory group to help inform decision-making or make the decisions for how funds should be invested. And in 2023, folks at Hopkins partnered with KFF Health News. Denny mentioned some of their reporting already, and an organization called Shatterproof. And we looked at the councils that have been made to look at or to make decisions around opioid settlement funds. This is a summary of the nationwide totals of the folks who are serving on those boards. And you can see that there is a heavy representation of elected officials, people who work in government, and people whose kind of job it is already to make some of these big decisions. What we don't see a lot of is this orange bar, this 7% is people with lived or shared experience. I know Councilman Cohen is not on the call anymore, but I wanted to give a shout out to Baltimore City. Their executive order that was released in August also outlined a restitution advisory board. And on that board, there are 4 designated seats for people with lived experience, which means that 30% of the voting seats on that board are for people with lived and living experience. So definitely variation in how these boards are set up, but I think making sure that there is representation in that decision making is really important. Our last principle is to create a fair and transparent process. And a lot of this we've talked about in the other 4 principles, listening to communities, listening to the data, disclosing how decisions are made and being transparent to the public about what the decisions are and how they were made. And then also evaluating the decisions to see if the investments are having the intended outcomes. Here are some building blocks for transparency that I always point jurisdictions to when we're talking about transparency. The input data, how much money has been received and from what settlements, what investments were made, what was funded, for how much, and to do what. I think a lot of times jurisdictions are reporting what money goes out, but not why it went out. Then reporting out the outcomes. So what did the program do? What impact did it have over time? And then also disclosure of the process. How did it go? Who made the decisions? How were decisions made? Are meetings public? Are the minutes public? Things like that. There's a lot of pieces to transparency. And so jurisdictions can think about building out a transparency plan and making that plan public so folks know what to expect. We have partnered with the National Association of Counties to build out what we call quick guides, so that dig into some of these things that I've mentioned. So we have one on doing a needs assessment, creating a council. We also have one on removing policy barriers, and one on monitoring settlement spending. You can find these at the NACO website. The URL is in the bottom, but if you also just Google NACO Opioid Solution Center, you can find them there. We also have a website called opioidprinciples.jhsph.edu, where you can find the resources that we've made, but we also have a curated tab that includes resources that other groups have made. And so if you're interested in any of those resources, or if you'd like to get in touch with me, my contact information is here. Thank you so much.
Thank you, Sarah. That was excellent. Go ahead.
Thanks so much, Denny. Hi, everyone. It's my pleasure to introduce Kathy Schultz. Ms. Schultz currently serves as the director of the Governor's Overdose Task Force at the Executive Office of Health and Human Services in Rhode Island. Her role as the task force director includes ensuring alignment across all strategic pillars, namely reinforcing comprehensive prevention, strengthening harm reduction and rescue, increasing engagement in treatment, and supporting recovery. She also ensures that racial equity is embedded across all pillars, uplifts community voices, uses data to drive change, and builds connections to care. Please welcome Ms. Kathy Schultz.
Thank you so much. Can everybody hear me?
Yes, we can.
Perfect. I usually talk pretty loud, but I want to just make sure. So thank you, everybody. I'm just going to give kind of an overview of kind of how our infrastructure here in Rhode Island worked and how we were able to really look at the allocations and put our strategies that are already in place together so that we could move towards addressing the overdose crisis here in Rhode Island. So I'm going to start us, sorry about that. I'm going to start us off with just a couple of level setting of our statutory role of the Executive Office of Health and Human Services here in Rhode Island. EOHHS is where my position actually sits as the director of the Governor's Overdose Task Force. And EOHHS is actually responsible for the oversight and coordination of state administered health and human services, looking at data evaluation, policy goals, resource use, and outcome evaluation. And also, I just want to note that you will see later in some of this presentation, EOHHS is also who staffs the Opioid Settlement Advisory Committee, as well as now the Governor's Overdose Task Force. So as you can see here, there was an executive order that was signed in 2022 that actually charged the Executive Office of Health and Human Services to hire a director of the Governor's Overdose Task Force, which is me. And my job is really to look at all things overdose, identify gaps, strategic planning, tracking progress, ensuring community engagement, and sharing data through clear goals and metrics on public dashboards across multiple agencies and partners. So that just helps to kind of see how our state is designed with our overdose response. So this is just the framework of our Governor's Overdose Task Force. I'm going to start with a little bit of history of this. The Governor's Overdose Task Force actually started to be convened in 2014 under an executive order in 2015 under our former governor, Gina Raimondo. There was the task force was formed, and basically it started off with coming up with a strategic plan within 90 days and setting a goal. And during that process, it was designed and it was created to have 2 state co-chairs, which was the Department of Health and our Behavioral Health, or a BHDDH here in Rhode Island, as our co-chairs. Then we have membership, and then we also have community participants. So the membership includes community participants, providers, most of the sectors in the state. And then from there, we actually have a multi-sector framework that is still in place with the task force. That has not really changed. What has changed, however, is through that executive order that created my position. In addition to that, we also added a community co-chair, because one of our main goals is to make sure that we have community voice throughout all of our decisions and all of our planning across the state. And we also have 9 community co-chaired work groups. And what that means is there are 9 there are community co-chairs who also receive a stipend for the work that they do. But we also, each one of those work groups is also staffed by a state co-chair. So therefore, we are continuing to make sure and ensure that we have that private and public partnership and coordination in all the things that we do across the state. Now I am going to bring us into the overview of the Opioid Settlement Advisory Committee. The Opioid Settlement Advisory Committee was in response to the opioid settlement funds. And this body was actually written into the settlement agreement, and it is designed similar to the structure of the task force, but it is separate from the task force. What we do though, is we make sure that the Opioid Settlement Committee and that the Governor's Overdose Task Force work together. And how we do that is we really, and you're going to see it a little bit later in the process that I'm going to show you, is what we do is we really utilize the task force infrastructure that already exists. It is the largest stakeholder meeting that we have in our entire state. Of all the meetings that we have, it is the most well attended, and it allowed us to be able to get that community input and just bring that over into the Opioid Settlement Advisory Committee and help to inform the decisions and the allocations of these funds. Unlike some other states, Rhode Island is very small. I'm sure you all know that. We're not New York. We're not Long Island. We are Rhode Island. And Rhode Island, we were able to negotiate that 80% of all of the opioid settlement funds is actually through the state, and only 20% is through the municipalities. So we are actually making decisions on the largest pot of that opioid settlement funding. And so here, I just want to show you very quickly Rhode Island's approach to the overdose response, and this is our alignment. As you can see here, this is our strategic framework that was developed to also increase continuous alignment. Here in Rhode Island with my colleagues, everybody knows my favorite word is alignment. I always want to make sure that when we're doing anything that we do across all of these strategies, that we're really looking at the alignment. And it's not just the state funding, and I don't know, I know that many of you can probably relate to this. The opioid settlement funds, we also have some state stewardship funds here in Rhode Island. There is a lot of federal funding that is also coming into our state, and we want to make sure that all of our decisions are also aligning with the funds that have been here for many years, and that we're trying to sustain the programs that we are funding right now or that we're allocating, and that we're doing this in a very strategic and aligned and coordinated way. And here is just looking at our overdose governance structures. So how do you do what I just said? It's not easy, right? We need to make sure that all of our agencies that are doing this work in our state, the Executive Office of Health and Human Services is the umbrella for our behavioral health, our Department of Health, our what we call DCYF, or Department of Children, Youth, and Families. We also have a DHS department. We have Office of Healthy Aging. And what we do is we're bringing all of them together. We're bringing them together at a level 1, which is the highest level of the secretary and the directors of these agencies. Level 2 is more of that interagency strategic and implementation oversight. And then, as you can see here, level 3, that's our agency work teams. That's our data and evaluation, fiscal, oversight, program operation, and program planning. And we do this strategically because we want to make sure that we are staying aligned and that we're communicating with one another. And it doesn't have it here, but in the middle of all of this is always the community voice. And that is what we really want to make sure that we are always focusing on, as well as equity, racial equity, making sure that we're adhering to populations that are disproportionately impacted across the continuum. And here is kind of the framework that I was speaking to earlier. Every year, we are able to utilize the Governor's Overdose Task Force by going to our work groups. That's where we start. And we provide templates, and we basically provide them with a copy of the strategic plan. And we ask them to provide to us 3 to 5 activities that focus on sustainability, evidence-based strategies, and strategic plan alignment. And then from those work group recommendations, each of the work group, they collect this information from probably close to anywhere from 500 to 1,000 people. They go through their process, and then they hand that over to me. I put that together, and then I present it out to the task force, which is our main body that the work groups report up to. And then I finalize those, and I'm able to bring those to the Opioid Settlement Committee as a reminder of what the task force or the community is still setting as their priorities. And then here is how the process of aligning the investments to the overdose strategic plan. I'm going to show you a little bit about the strategic plan, but one of the things that I want to just so that you all can follow me is it's really important to remember that when I came into this position, the opioid settlements had just entered into our state. So one of the things we had to do, and the first things we had to do, is actually do a strategic refresh. And that was getting the priorities from the work groups, from the overdose task force, as well as the Opioid Settlement Advisory Committee, and the community, and kind of putting that all together and consolidating and duplicating all of those action plans to make one action plan. Because having 4, it gets very confusing, and it's almost impossible to evaluate that. So as you can see here, and that's why I left it on here, I'm not going to read all of these because it's a lot of information. This is the process, and you can see how it kind of works, where you'll see the key here where EOHHS, which staffs the Opioid Settlement Committee as well as the task force, is and their role in this, and then also the Opioid Settlement Advisory Committee, the Governor's Overdose Task Force, and the state budgeting process. And then here we have the state budgeting process in more detail. And I do know that these slides, I believe, are going to be shared, so you can look at these more carefully. But I'm not going to read them all off. And I'm sure it's similar to many of your other states, but we basically have to go through the Opioid Settlement Committee, our state agencies, governor's office, and then the General Assembly has to approve those. And now we're going to look at the strategic plan and target. Now, I gave you a little bit of information on this, but this is going to give you a little bit more of an illustration of what I was saying to you all. So here, this is our main focus. Whenever we do anything in our state, we really want to make sure that we're thinking about the continuum of care. And across all of this, even though it's not highlighted here, the main things, there are 4, I think it's in the cross-cutting. There are cross-cutting priorities that we're going to get to in just a moment that I just want you to think about, but this is kind of what it looks like. We're thinking about social determinants of health. We think about harm reduction, treatment, and then we know that sometimes people have to go back through that process again because recovery is not linear, and harm reduction doesn't always require recovery. It doesn't always require treatment. What harm reduction is really investing in life-saving initiatives while we're redesigning the systems. And then as you can see across the bottom, we really focus on prevention, investing in our youth, our community partners, in systems to curb substance misuse and addiction, and making sure that we are trying to address the challenges that our youth are having, especially when we think about COVID-19. We know that statistics are showing us that our youth have been extremely impacted by that. So that is a main priority for our state as well. And you will see that in our investments as well. So here are the guiding principles, and I believe that others are using these guiding principles. Rhode Island, I adopted the guiding principles for decision-making through our opioid settlement committee, and we try to make sure that we adhere to those in all of our decisions. We make sure that we remind the opioid settlement advisory committee each and every time that we're thinking about making recommendations each year. I know in some states you may be doing budgets that are multiple years. We hope to get to that point, but right now, because of the way our state fiscal year works, every year we're really taking a look at each and every priority area. And here is one of the things that our state is really tried to implement right away. So there's one thing about, and this is about operationalizing equity across all our overdose responses. So we can say that we are focused on equity. You can say that that's something you want to do. Even in the task force, we said we wanted to ensure that equity is part of the conversation across the board. But how do you operationalize that? So these are some of the key things that we have implemented, and this includes what we're doing as state agencies. That is making sure that we have a paragraph that is specifically telling our partners, our community partners that we are investing in, that they do need to show us how they are going to ensure equity, how they are going to ensure that they are using class and ADD compliance and trainings, using people with lived experiences on review committees within the state, as well as we're also making sure that that is implemented into our contracts. And as you can see here, there's a lot of information here, but this is basically the approach that we're using to make sure that we're operationalizing equity. I can't say we're doing it perfectly, and I don't think anyone is doing it perfectly, but this is something that we have committed to, and we're lessons learned, and we're trying to do a better job each and every time, each and every year. And here's our strategic plan. I explained a little bit earlier about how we came to this strategic plan. And I just want to share with you all, when I started in this position, it was about 3 months of sitting with hundreds and hundreds of strategies and priorities and recommendations. And what I really did was I honestly sat down with a spreadsheet and I consolidated and deduplicated those all, and we came up with these. So as you can see, 1 through 4, I'm going to go a little bit backwards. These are our main pillars that have been in place since the Governor's Overdose Task Force started in 2015. And that's reinforcing comprehensive prevention, strengthening harm reduction and rescue, increasing investment in treatment, and supporting recovery. But as you can see at the top in blue, these are our cross-cutting pillars. And what this is ensuring racial equity and eliminating disparities, building strong governance and community engagement. And when I say governance, what that means is evaluation, that means administration. We have to have those things in order to use the funds in a equitable as well as evidence-based practices, making sure that we're accountable and we're transparent with what we're doing with the funding. And then expanding data capacity and surveillance, because we can't do anything unless we're making sure that data is being put into action. We want everything to be backed up by what the data is telling us. And then, of course, addressing social determinants of health, basic needs, housing, trauma supports for our first responders, which includes our peer harm reduction outreach workers, because they are on many occasions, actually responding to overdoses. And it's very traumatic. It's traumatic for our EMS, for our law enforcement, and we are also investing in that as well. This is our overarching overdose targets. So as you can see here, I kind of went over this. We have set a goal. We use the same process that we use for the strategic planning, and that is to reduce fatal overdoses by 30% by 2030. In addition to that, we know that we need to increase the quality of life or improve people's lives. And here is where we are with overdoses, and I'll zoom through. But I want to make sure that I tackle this because this is about equity. And I think this is really important. We did see a reduction in fatal overdoses, but what we want to make sure is that we're seeing reduction in fatal overdoses for those who are directly or disproportionately impacted. And we are moving in the right direction, but we still have a lot more work to do. And then ensuring transparency. This is just a quick snapshot of our public dashboard that we have. And if anybody's interested, I can put the link to this webpage and you can take a look at it yourselves. And that's all I have. Thank you.
And I want to make sure that we get Rayford Etherton in here. He's the founder of the Elios Alliance, which has constructed a national opioid abatement simulation platform that can be used to guide policy and spending decisions. And they've built a public-private partnership to develop an Alabama-specific simulation model that will be made to all cities this fall and this year. So Rayford, let me not belabor anything. Please go ahead.
Okay, if we can get this slide up, yes. Okay, can everybody hear me now?
Yes, we can hear, we can see, everything's good.
Okay, good deal. Thanks a lot. Denny, thanks a lot. And I'm going to try to honor this 10-minute window that I have here. So I'm going to do some things in summary, but I would like to start out by saying that it's an honor to be a part of this panel. And I've learned a lot this morning already. And I'd like to share with the people that are listening that Denny on her email sign-off says, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. That's from Margaret Mead, and I don't think truer words were ever spoken, and that's actually what we tried to do starting here in Mobile last June. And so you'll see a slide here that shows what we call the Helios Alliance, which is a group of folks who are committed to using evidence-based transformative technology, predictive analytics to try to help decision makers spend these opioid settlement dollars in the smartest and most efficient way possible, recognizing that, as Zeke said earlier, that systems change is a long game. And so we're trying to take that approach. You'll see here that we are a public-private alliance partnership, and we do view it as a partnership. And I'd like first for you to hear from one of our local leaders, who is the executive director of the Drug Education Council, which has been the platinum standard in their area of the world for almost 60 years. It's just a couple of minutes, but it kind of frames the rest of our discussion. Okay, that's fine.
This is the deadliest time I've ever seen for drug use. And so I really am thrilled that our community is addressing this in a very robust way. And I think we've got a plan that's not only good for the Mobile and Baldwin community, but also the entire state of Alabama and even the United States. This is one of the most innovative ways of addressing it. It's a scientific model. You know, it's got ways that we can know that where we're investing our money is going to make a real difference. I also think the people involved realize that this is a long-term commitment. And so we've, in order to change our world, it's going to take a while, but we've got a real good plan now, and that's exciting. Everything out on the street, online, that you get from anybody other than prescribed for you and filled at a legitimate pharmacy should be considered deadly. We know that probably 70–80% of the drugs on the street are tainted with fentanyl. You never know; it can be a deadly amount. There's a program we do called One Pill Can Kill. Because now we're seeing people that aren't even maybe addicted that are still using. They just get a pill from a friend, and it's got a deadly amount of fentanyl. This is the deadliest time I've ever seen for drug use, and so I really am thrilled that our community is addressing this in a very robust way. And I think we've got a plan that's not only good for the Mobile and Baldwin community, but also the entire state of Alabama and even the United States. This is one of the most.
That's already done. Okay, so if you go back one more. Okay, and so thank you, Virginia. And you'll see here the base components of an abatement plan, which are treatment prevention, what we call survival programs, coordination, and communication, which we think is essential. This is taken in large part from the lead that Johns Hopkins took at the beginning of this, and we all are thankful for the work that they did to create this blueprint for us as we move forward. So what is different about our approach? We use system dynamics modeling as the core technology. Basically, what it allows a person to do is that it has three things that matter in our context. The first is it allows us to understand what would have happened, but for certain designated events. It helps us to predict what is most likely to occur if certain courses of actions, policies, practices are adopted. And it also allows us to identify gaps in complex systems so that if we could leverage those gaps, that we could improve the performance to more likely achieve the outcomes that we desire. What I'm showing you here is it's the components of what a policy model look like. You'll see the different categories that are in the abatement policies. And one way to understand what we do is if you think about these slides, these pieces of paper that you see here as a card deck, and then you had four stacks, 4 buckets of abatement, except this time you can turn them up where you see what's there. Our modeling approach allows us to shuffle those decks in different ways to see which combinations of policy recommendations are most likely to be successful, the ones that are most likely not to work, and where there are gaps in the system that we need to explicitly address. So we have taken that from an idea back in June by taking the National Opioid Abatement Model, translating that to a state of Alabama abatement model. And then we have further made that model more granular to take into account the area around Mobile, which is a city of about 10,000 people in Alabama, second largest city in the state. So what we were asked to do was to use our modeling expertise, our team that we put together, to develop a model-driven analysis to come up with a robust RFP process, and then to make recommendations to the city on how the fund should be deployed. We will explain in a second how we think that program has been successful. And we've identified, taking a look back at what we believe the keys to success were, is that we actually treated this almost as a political campaign with a strategic messaging and media push to the public beginning 3 months ago. We kept in constant and intentional collaboration with key city leadership, the mayor's office, the city council, the city attorney, and leaders across the community, because we do believe, as Zeke said earlier, that a community-based intentional infrastructure is key for this to work, not only in the first year, but in the decade or so that are going to follow. We engage with organizations and citizens throughout the community that have been involved in this process since the beginning, so that we could meet people where they were as we go about the process. And we are continuing that today. One thing that I would like to add at this point is that as we went about the process, the RFP process, we wanted to do everything we could to level the playing field so that people who had good ideas that we think would meet what we call the touch points of the first modeling exercise. We wanted to give everybody the level playing ground to present their ideas, their proposals. We intentionally encouraged people to collaborate with one another where they had shared interests so that the dollars could have the biggest impact in the community. We conducted 2 community-wide meetings to explain how the modeling fits in with what our task here were. And we're very pleased to report that in the city of about 200,000 people, 40 different community organizations applied through the RFP process. Those were 33 separate applications. Obviously, a good deal of collaboration among those organizations. We began that process in September. We'll be in a position to make recommendations in December. More than $7 million in funds were requested against an available $2.2 million. And so we're very excited about the types of proposals that we're seeing here, and that they run the gamut and they do cover all 4 buckets of the abatement task that we've talked about. We're also happy. Our idea was always to start locally with this process and hopefully to expand it so we could actually have a statewide or regional impact. We've been endorsed by the Attorney General of the state of Alabama, who opened a summit that we hosted a month or so ago here in Mobile. He's encouraging other cities and counties across the state to follow the lead of the leadership here in Mobile. Our mayor has been an advocate since the beginning last June 2023, and has been a very engaged partner with us throughout the process. And the city attorney I will say, I will read what he said, that being able to collaborate with outside entities that couple together information and modeling and actually looking at that information in a systemic way and then moving forward based on that information is very exciting. We agree with that. I think I have about 30 seconds left. And I would like to mention that throughout the RFP process, we thought it was important to scrub the applications to remove any kind of identifiers for who the organization was as it was being considered by our evaluation committee, which is made up of community leaders, no elected officials. We do cover those points that Sarah mentioned. We thought that was very important. And we've had a training process with those evaluators that began about 2 months ago, and we'll actually have their midway meeting tomorrow. So I know I probably rushed that, but I think I finished up with the key points. So I'll turn it back over to you, Denny.
No, I'm so sorry. There's still quite a few people on if you have any other points that you want to make.
I'm happy to address questions. I guess let me go back and take a look. I think I actually covered the main points in the same, but I would like to reiterate, the comments that the prior panelists made, particularly Zeke and Sarah, about the importance of having this community infrastructure. And so that the people who were a part of the process actually understand the role that the technology we're using plays and how they go about making their decisions. Mm-hmm. We think it's very important for them to have confidence in the approach itself, the underlying analysis that we're doing. And we believe as we take this statewide, we're in discussions right now with a very large county following the NACO principles that Sarah discussed. And I'm very happy to announce that we've been retained to work on a statewide basis in West Virginia with the Office of Drug Control Policy. that's headed by Dr. Stephen Lloyd, who I'm sure that a lot of you know, who's one of the leading abatement experts in the country. So we're very excited that we're able to do what we hoped we could, which is start locally, expand the scope of the work with others so that we could start to have a consistent regional impact on how these dollars are spent, and to make sure that they get to the people that are most affected in a very transparent, evidence-based way, that we can measure those outcomes as we move forward, to make the necessary pivots in our modeling to take into account new challenges that appear, like the new synthetic drugs that we're all seeing in different parts of the country.
Yeah, I think that's such an important point too, for people to be using this kind of technology. It really facilitates their decision making and also allows for evaluations around the country with different states and localities to determine really what is working best, what isn't, and what isn't. And so with that kind of standardization, we can really better understand where to invest our money so that it'll be best used. So I think it's great. Somebody has asked if there's a demo or video of the technology. I don't know if you want to state or put into the chat your website.
Actually, if you'll go to our website,
Mhm.
theheliosAlliance.com, you will see a resources page that includes a lot of the of articles, information about the methodology itself. We're happy to do any sort of presentation that anybody would like. Just contact us through that page. And Denny, the point that you made there is really is a good one. Is that we already found, and I don't want to intrude on or invade the decision-making process. I'm not a part of the evaluation committee, and as they go about their work, but our modeling analysis has already shown that some conventional wisdom does not actually play out in the real world, which is why what the work your organization does is so important, to focus on science, evidence, and technology that has been vetted and worked over the decades. And that's what's really exciting about this, is to come up with new ways to approach this process, as opposed to some that we've done in the past.
Right. I think it's great. I can't thank all of you enough for your spectacular presentations. This was really excellent and so valuable and instructive for all those who are listening. And we will soon, probably in about 2 weeks, have the recordings, the slides, resources available on our website. Everybody who registered will receive the link. So thank you again, and I wish you all well, and in advance have a thankful Thanksgiving. Take care.